I think we can slowly start.
So, hello everybody. My name is Magnus Tisell, and I'm chair of the Global Humanitarian Committee for EANS. And I'm very happy to start the very first webinar that our committee has arranged. And it is a very good subject as well, because it's a very global subject, which is about neurotrauma, which is a leading cause, as you know, about death and disability all over the world. And I'm very happy to have a very distinguished lectures here from 3 different continents to give us different perspectives. And I thank the lecturers so much, and I also thank Niccolo Marchesini and Leandro Santos, who are the committee that has arranged this meeting. Leanne cannot be here today, unfortunately, but Niccolo is here as well. And I just want to illustrate. So I was to share screen. So for me, I just show a short illustration of what we're talking about today. This is a photograph we took a few months ago when I was in Sierra Leone in Africa, and we were driving 60 kilometers per hour, and then we saw this gentleman at the same speed in his wheelchair behind this small vehicle, and it kind of illustrates the problem. I don't know exactly what he had, but it's quite likely that he's in the wheelchair because he has a previous spinal trauma, and it also looks it's quite likely to have an upcoming skull trauma. He just have his glasses as protection. And it's in a very hazardous traffic environment. He's a young male at the highest risk of having this trauma. And finally, and not at least, he's in a country, Sierra Leone, where you have no access to neurosurgical care at all, actually. There are some treatment of head injuries, but there are currently no neurosurgeon in this country. So it kind of illustrates also the lack of access. So this is a kind of illustration of what we are talking about today, and we will have 3 different speakers from the 3 different continents, and the first one will be introduced by Niccolo. And we also want to remind that we are quite sharp on the 15 minutes, so because we want to have room for questions in the end. So that's all from me. So please, Niccolo.
Hi, good evening, everyone, and thank you, Magnus, for the warm introduction. I am very humbled to be here for this very first webinar of our committee that, as you mentioned, is specifically studied to raise awareness on specific issues in the field of global neurosurgery. And as you said, the first webinar will be about neurotrauma, as it's still a very emergent topic all over the world, especially in low and middle income countries. So I don't want to steal more time to our esteemed speakers. As you said, tonight we have 3 first-class speakers in the field of neurotrauma worldwide. The first speaker I wish to introduce is Professor Lynn Lours, who kindly accepted our invitation to join despite the time difference with Philippines. Professor Lours has a prestigious background in the field of neurotrauma, and I only mention her most recent position, as she is currently the chair of the Neurotrauma Committee of the Asian Australian Society of Neurological Surgeons. So Professor Lours will give us a lecture titled Task Sharing Neurotrauma, Addressing the Scarcity of Neurosurgeons in the Bicol region in Philippines. So Professor Lours, the stage is yours.
Hello. Okay, I'll just share my screen. Okay, so aside from what we were mentioning as task sharing, I'd like to bring up the topic of how we advocate for neurotrauma care and surgery in this limited resource setting in general. Okay, so disclosure, none. So this is my area, the Bicol Regional Training and Teaching Hospital, which is now called the Bicol Regional Hospital and Medical Center. This is actually my operating room suite. And this is my area. So we have an active volcano in nearby. Okay, so as we mentioned, neurotrauma care and traumatic brain injury in particular has been sort of not within the limelight before, but during the past decades, we have seen improvements in acute treatment, like emergency room, especially the ICU care units, and surgical procedures, and also intracranial pressure monitoring, seizure control, and also all these areas of endotracheal intubation and even sedatives and blood pressure control. But still, we all know that neurotrauma is a global health problem. In fact, the WHO has said that this is the burden of disease of neurotrauma causes 11.8% of total global disability. So neurotrauma is brain and or spinal cord injuries. So the highest and lowest portion of road traffic accidents and traumatic brain injury, according to Delwan, highest is in the African region and the Southeast Asian region, ranging 34%. And the lowest is the region of the Americas, the US and Canada, around 29%. In the Philippines, where I am here located, our population is around 117 million to 2023 estimate, with an archipelago of more than 7,000 islands. So road traffic accidents is mainly more from motorcycles. 4.8 of 8.7 million vehicles are motorcycles here. So there was a 45.76% increase from 2006 to 2015 of deaths from road crashes. So it's also a leading cause of death in less than 24 years of age. So with this, there is not much brain injury or even neurotrauma advocacy before. Unlike in other countries, there are a lot of programs and creating awareness and also associations advocating for neurotrauma. So we all know that the effects of traumatic brain injury is not just physical. So we all have loss of possible loss of motor skill and also sensory loss. But there is the thing of behavioral and cognitive problems. Okay, so these are the things that a lot of people here in our communities do not know yet that these are all part or possible effects of neurotrauma. Meaning when they say, they just sort of dismiss it, like for example, they say there's a behavioral change of this patient, they will attribute it as because it's possible effect of neurotrauma, and then they don't do anything about it anymore. Okay, so they just say they accept it. It's the effect. But what next? So can you imagine, for example, a young male will just be confined at home without any other further use or importance or significance of his life because there's a behavioral change or maybe post-traumatic depression, and it's not addressed. So the physical complications, there has been therapy and neurorehabilitation, but the reality in our setting is that there's not a lot of rehab medicine doctors even. Here in our area, with around 5 million people, there's only one rehab doctor. So, but there's also a lot of physical therapy therapists, but they do not really stay here, like they migrate. There's a lot of demand outside, so they go out. So the neuro rehab is not that established yet here especially in rural areas and provincial areas. So more so, the address of behavioral sequelae or cognitive sequelae, there is not much of emphasis in addressing, for example, the post-traumatic depression or even behavioral problems because they have not really known about neurocognitive care. So the recognition should be done in these areas so that awareness could be created. So sometimes, for example, like me, a neurosurgeon, when I started practicing way back in 1999, I was the only one for around 4.5 million people. And I, s- I had to act not just as a neurosurgeon, but also even in my clinic, I had to advise them about rehab therapy, how to do some physical exercises, even encouraging them family support, sort of acting like a counselor or a psychiatrist, and then advocating for play therapy for kids, and also voice therapy for those who have had aphasia, and also neurocognitive rehabilitation. So behavioral problems. So what I'm saying here is teamwork has been emphasized, and a multidisciplinary approach is very important. But it has not been emphasized before here in our setting. So the strengthening of all this cooperation and the multidisciplinary team approach has been in our program. We want to create this. So we even had this first Philippine Neurotrauma Bootcamp from injury to recovery before. Last year, we started this already. So these are the modules. We have acute critical rehabilitative preventive care from injury to recovery. We covered a lot of topics in a 3-day course. So we even had breakout topics or sessions, and there was combat and mass casualty neurotrauma management protocol, first responded EMS protocol, first contact physician management protocol. So all these things, from workplace and school neurotrauma to even geriatric neurotrauma to patients with pregnancy neurotrauma in that kind of patient. So we covered all that. So this was actually featured in the World Federation of Neurosurgical Societies as one of the activities in their newsletter. So this was part of pictures, like we invited Dr. Professor Sina and Professor Punya from India. They came to speak, and we had virtual attendees for the 3 days. We had 1,052 unique viewers from day 1 to 3, coming from Vietnam and the Philippines and other countries. And top 6 specialties who attended were general practitioners, nursing, pediatrics, neurosurgery, general surgery, and neurology. So all of these speakers came from the AASNS, and also our local speakers from the Academy of Filipino Neurosurgeons. So what's next? So in neurotrauma, especially in operating patients, we have advocated for not just awareness, but also I have been teaching a lot of general surgery residents to do neurotrauma, which is what we call task sharing. So with task sharing, I have taught them to do emergency, life-threatening operations like epidural, evacuation, and also acute subdural evacuation, even decompressive craniectomy. So aside from teaching residents, general surgery residents within the program, we will conduct more awareness down to the grassroots level, meaning down to the EMT, to the frontliners of neurotrauma. So we will be holding more boot camps to encourage cooperation and collaboration. And we are establishing actually the Neurotrauma Society of the Philippines. So within this, we will have website for education and awareness and advocacy, and we will tie up with other neurotrauma societies in the world. So and we will participate in conventions and advocate videos on road safety in tying up with the Department of Health or the Ministry of Health in our country. So hopefully we will have more policies on neurotrauma, because we don't even have a neurotrauma registry here yet in the Philippines. So this is one of the things that we want to achieve. And also local guidelines. I know there are a lot of guidelines like Brain Trauma Foundation guidelines and other guidelines in the world. But as we have been saying, we think global, but we need to advocate for the local. So we need guidelines for the local environment, the local community. So we need to have the government and other sectors involved. So from injury to recovery, the multidisciplinary team approach, we will have our Neurotrauma Society of the Philippines. So cooperation embodies that means to solving any problems, we have the resolute endurance to resolve. So thank you for your kind attention. I invite you all for a physical conference at the 18th Asian Australasian Conference in Manila in 2026, May 2026. So please email me. So again, thank you for your kind attention. So was I coming in clear?
Yeah. Thank you very much, Professor Lutz. It was a very brilliant presentation, and thank you very much. I just remind to the whole audience that they have the possibility to ask questions in the question and answer section here in Zoom. And at the end of the 3 talks, we will ask the questions to our esteemed speakers. So I move on to introduce the next speaker of our webinar, Professor Andres Lubiano from Colombia. He is a full professor in neurosurgery at University del Bosque in Bogota. About Professor Lubiano, I just mentioned the last, or better, the most recent role position, that is the president of Neurotrauma Committee of the World Federation of Neurosurgical Societies. And it's, of course, a real honor to host him here tonight. So I don't steal more time to Professor Lubiano. So the stage is yours.
Thank you, Dr. Marchesini, also to Dr. Tisel for this great invitation. So we are going to share our experience that is very linked to what Professor Lucen just mentioned. I'm going to share my screen. So now it's working?
Yes.
Okay, perfect. The sound is also good?
Yes.
Okay, perfect. So I'm going to speak briefly about decision-making in neurotrauma in less resource settings. We are going to briefly speak also about the Bootstrap protocol. That is an initiative that we started here in Colombia in 2017. Now is spreading many of the associations that are working in this topic, and we hopefully can have soon the final results for the clinical evaluation of the impact of this type of. I don't have any conflict of interest, so we are just involved in many of the activities of many of the Global Health Research Group, specifically the one that is supported by the National Institute of Health at the University of Cambridge, and also in international activities of Global Neurofoundation and the Brain Trauma Foundation. So we are very aware of the difficulties around the world with this pathology. TBI is a very important pathology that affects mostly young population, economically active population worldwide, especially in Southeast Asia, Africa, and Latin America. So I think we are really a group of representative of where the problem is. This is all related to the Human Development Index. We know that this is the new metric that is used for evaluation of the development of the nations and the regions of the world. And we have here a very good picture of how the development is established worldwide. So as we mentioned, Southeast Asia, Africa, and some areas of Latin America, including Central America and the Caribbean islands, are areas that are considered still in the process of developing, that include not only the income, but also the education aspect and societal aspects in the process. When we talk about low resource settings, there are many factors that affect this context. This is all really important to take into consideration when we are talking about decision-making and protocolized management, and also guidelines application in this type of settings. We all know that there are geographic and environmental factors that have been mentioned, financial shortage, there are paucity of knowledge in some areas, there are underdeveloped infrastructure, restrict social resources, there is also influence of belief and practices, there are human resource limitations, suboptimal healthcare service delivery, and research challenge when you try to understand what is happening in this type of environment. So many of these considerations need to be into account when you try to decide how to manage patients and how to apply protocols and guidelines. The Lancet Neurology Commission recently published many of the results of the Center TBI and the Track TBI studies, and it has been identified that pre-hospital care is one of the most important factors that are affected in LMICs. So this means there is an increased second insults in many of these patients. Sometimes there is not appropriate way of organize the triage in these patients. There is little evidence for specific populations like elderly patients. As has been mentioned by Professor Lucen already, there is limited access to rehabilitation. And all these aspects needs to be into account when you have possible aspects for improving care. So in order to improve quality of care in many LMICs, there are areas that need to be tackled: primary care, basic emergency care, and in general, the public health systems. We need to do capacity building, including education for family, community healthcare workers, clinicians, as has been just presented by Professor Lucen. We need to improve capacity, especially focusing on leveraging surgical and critical care expertise, supporting capacity building for developing TBI clinical research that we already know that is limited and have many barriers, and definitely investment in education and development processes where limited resources are present. So taking all this into account, the most suggested interventions are definitely to explore innovative methods and preventive strategies. So we need to generate a lot of innovation, thinking out of the box of how to implement the care in this environment. We need to develop simple triage tools, protocols, and care guidelines that can be modified according to the resource limitation that can be used even by healthcare workers that have limited clinical backgrounds. All these have been already tested and evaluated, not only in TBI, not only in trauma, but in other sources of pathology. We know that there have been some guidelines that have been very focused in this type of environment. There are just brief examples here. The old guidelines of the Neurosurgical Society of Australasia were developed in 1990s for the rural areas and remote locations in Australia. The recent TBI guidelines for India, and also some of the guidelines that we have been developed in Colombia that are focused in many of these environments. But the issue is when you bring all these guidelines that are available worldwide to real scenarios, there are many limitations because if you want, for example, to apply directly the VTF guidelines in many of these centers, there are even areas that do not have a CT. We have here some brief examples of emergency rooms that can take care of these patients or even ICUs if exist. And we know that there are areas that have many limitations related to technology and infrastructure and manpower, as we mentioned. So the question is how we are going to apply just one guideline for all these heterogeneous scenarios. We have been working since some years ago in the testing of many of these protocols in different environments. Since the trauma care checklist application of the WHO that we start evaluating in 2010, some of our standardized trauma care protocols that we did in some of our centers in 2014 and 15, and also the application of new technology until the bootstrap protocol, that is something that we're going to briefly mention. If we take what is already around, we can have this protocol very well known, developed by Professor Chestnut and the Argentinian group of intensivists, based on managing and generating the decision making for this patient based only in the clinical exam and the CT. But as we mentioned, if there are no CT available, we cannot apply this protocol because it's based on the CT and the clinical exam. So we need to take this into consideration. And what we did was in 2017, we select a group of practitioners that were deployed in many of these different contexts. So people that were working very remote hospitals in the jungle area in Colombia, also in hospitals that, for example, have emergency and IC and surgical care but didn't have ICU, centers that have sometimes ICU but didn't have access to surgical ward. So all these kind of variations that we can identify in many of these contexts, and we put them to work together and develop some set of algorithms that can be applied in these different scenarios. So the main core of this project is explaining this image where you can have at the pre-hospital level patients that can be managed in very low resourced pre-hospital units where even they didn't have any kind of technology inside the transport vehicle or even people that is not trained, up to people that is well trained and have more technology that is identified by the green color here, something in the middle, teams that or have some sort of technology but didn't have the training, or have some sort of training but didn't have the technology. This is also a possibility. It's identified by the yellow box. And then from that, you can move to areas that have emergency room that have CT present, that is the small gray box here, or centers that didn't have CT. And in this direction, you can have also centers that have very low resources, so very low training, intermediate level of resources, high level of resources, and high level of training. And after this stage, they can move to areas that have neurosurgery available, or centers that didn't have neurosurgery available, just general surgery. And then they can move to post-operative care in areas that have full ICU context, or even centers that didn't have ICU available. So what do you do with a patient that is already operated, but you didn't have an ICU? So if you move him to, or the patient to the general ward, or you move to the, or you stay with the patient in the operation room, what are you gonna do there? So all these contexts represents scenarios that are real in the real world. So finally, after working a lot trying to publish this, because many people in the beginning didn't understand what was the idea behind this stratified protocol proposal, we finally published that in the Journal of Neuroscience and Rural Practice in 2020 after 3 years of working with different options for publication. And the most important thing is not actually the article, is the supplementary materials, because if you go over the supplementary materials, you can have access to the full set of protocols in each one of these different scenarios. You also have a specific supplementary material for a standardization of CT reading if available, and some other tables that can be used for the postoperative care. These are some examples, some of the material, how to read the CT if the CT is available. And then when you go over the specific protocols per se, this is a very free example of algorithm number 8. If you are in an area that does not have too many resources, you can apply only the red recommendations. If you are in an area that have intermediate level of resources, you can apply the red recommendations plus the black recommendations. And if you are in an area that have all the resources, you can move from the red recommendations through the black recommendation and moving up to the green recommendations that are the recommendations for centers that have more technology available. So at the end, these things have been very interesting and have been calling attention for many people in many regions of the world. We just recently presented this in a very important meeting in North America that is focused on how to improve rural trauma care. And they consider that this is a very important approach for how to manage these patients. And we are now in the second stage of updating the bootstrap protocols, integrating new technology. As we mentioned, innovation and new technology is very important for this type of settings. This is a proposal of a brief algorithm that we present in the human textbook of neurological surgery in chapter 392, where you integrate some of this technology if available, for example, pupillometry, optic nerve sheath diameter evaluation through ultrasound, or evaluating of intracranial bleeding by infrascanner devices. So if you have all devices can be integrated into these protocols in order to improve care in areas that don't have too many resources. So we have been developing the most recent years to understand how this technology can be applied in limited resources settings. You know, many of these technologies portable, is accessible, is not very expensive, and really can identify patients that require urgent care. So we are talking about improving triage, as was mentioned in the Lancet Commission, Neurology Commission report, and also generating innovation for integrating this into many of these protocols. So, for example, if there is no CT available, we can use the near spectroscopy device that can identify intracranial bleeding. Or if you don't have invasive ICP monitoring, you can move to technologies that can identify the ICP waveform non-invasively. So many of these technologies already in the field, and we just need to integrate that into the protocol. So we have been publishing a little bit about how to integrate in this for better decision making. For finishing, as has been mentioned by Professor Lucen, it's important to record what we are doing. This is an example of a neurotrauma registry that we are working with in the Latin American region. It's totally free and is very accessible, so can be integrated in many other regions. We are now speaking with some people that is interested in Southeast Asia in order to integrate this same registry, because it's widely available. It can be translated to many languages because it's already in a software that can do that. So it's very important to develop this sum of sources of information in order to understand if what you are doing or you are proposing really generate a difference in the outcome of the patient. It's important to integrate many of these concepts in the training program, in the formal training program. That's why we develop with the support of the University of Cambridge and in the past in the Barrow Neurological Institute, the Global Neurosurgery Fellowship Program. We have trained now more than 15 fellows from different regions of the world, even Southeast Asia and Africa. We receive regularly applications for many of these regions in order to train them in many of these new trends that we are developing. It's important to integrate this into continuing medical education programs. Fortunately, we have many groups that are interested through the regional associations and also some private groups, like in this case, Global Neuro Foundation, that have been very focused on developing specific programs. These are some of the examples. We just have recently one of the first African courses during the World Congress in South Africa. And all these can really need to be integrated into this model in order to change outcome. So this is everything that I want to mention. Thank you so much again for the kind invitation. You are very welcome, and people who is already working in global neurosurgery aspects or in global neurotrauma aspects are really welcome to come with us and have lived experience what we are developing here with our network. This is the Valle Salud Clinical Network. Is a trauma center that have a network of care. Our foundation, that is a research center locally here in Colombia, and now that we are integrating many of these knowledge with the Hospital Universitario del Valle and the Universidad del Valle neurosurgical program that is starting to work with us in many of these aspects. So thank you so much.
Thank you very much, Professor Rombiano, for your, as always, excellent presentation. Indeed, as you mentioned, the transferability of guidelines to real scenarios, as you mentioned, is a concrete issue. And as you showed us, to stratify the interventions according to the resources of really available in the context is really clever and I think personally pragmatic approach. So we will keep the questions for after the last presentations. So Magnus, if you want.
Yes.
Okay.
Thank you so much, and I also thank the previous distinguished speakers. It's been excellent presentations, and I have the honor to introduce at last, but not at least, my very good friend, Professor Enokuche from Enugu in southeastern Nigeria. He's a very, very prominent person in the West African society and active in the West African College of Surgeons and also in our organization, the Swedish African Research Group collaboration. So, Enoch Petruccia, you are welcome to take the stage.
Thank you so much, Professor Magnus, and thanks, distinguished audience. It's my pleasure to be here with us to present this topic on neurotrauma management in resource-limited settings with a focus on sub-Saharan Africa. I would like to start by saying that these are my affiliations: SANC, University of Nigeria Teaching Hospital, the Academy of Neurological Surgeons and West African College of Surgeons. Neurotrauma encompasses a very whole lot, and that includes traumatic brain injury, spinal cord injury, peripheral nerve injuries, and it's really not possible that we can, give a detailed talk on any of this within the time frame. So we're just going to make a summary of our experiences here in Nigeria, depicting what is available in most of sub-Saharan Africa. Well, by sub-Saharan Africa, we mean the non-Mediterranean Africa. So if you look at this map of Africa, you will see the part of Africa that is below the gray zone, and that includes about 46 to 48 countries in this part of Africa. Well, I'll start by saying that what we already know, that globally, the TBI incidence, the traumatic brain injury incidence, is estimated to be up to 27 million per year. And recent estimates have shown that there's a 3.5-fold increase in sub-Saharan Africa. Now, trauma accounts for 4.7 million deaths annually, and most of these occur in low and middle income countries, exemplified by the sub-Saharan Africa. Now, management of traumatic brain injury or neurotrauma is a multidisciplinary issue, as has been alluded to by previous speakers. Reviewing the burden of traumatic brain injury, in this study, a scoped review by Adeboyega et al. Essentially pictures what is mostly known, that this is a disease, a problem that affects young males disproportionately, especially those in between the ages of 20 to 40, and road traffic accidents being responsible for most of the cases. In sub-Saharan Africa, what is common is a delay in care, and that is because from the crash scene to the hospital may take from one day to many days, because there are anomalous routes that can be taken. Patients may be abandoned there, or they can be taken from there to a series of private hospitals or other small centers before they are taken to a place where they can really get help. All because you don't have a well-developed emergency medical services and pre-hospital care. Now, in the epidemiology of head injury, the work by Adeolu, one of the neurosurgeons published in the International Journal of Epidemiology, actually reported over 1,000 cases, also showed a young mean age, and also showing that road traffic accident is the most common cause. Nigeria has a public health system that includes over 27,000 primary centers and over 1,200 secondary centers and over 100 tertiary centers. Now, payment for healthcare in Nigeria is mainly out of pocket. And in fact, in 2018, it's estimated that only about 3.3% of patients surveyed are covered by health insurance. Now, looking at the burden of traumatic spinal injury, another scoping review by Damilola et al. Published in 2023 in World Neurosurgery. Is included 13 studies with some sort of a Nigerian bias. And the number of patients included in the study was about 1,332. Now, this paper shows a significant geographical variation, with lowest incidence of spinal cord injury in Botswana and highest in South Africa. Again, road traffic accident and falls were the major culprits. I'd like to share this experience. In one of our papers examining the epidemiology of spinal cord injury, in the 70s, a previous paper, a paper that was published on the epidemiology of spinal cord injury, showed falls to be the main cause. And this was because during that time, palm oil farming was very lucrative and a major source of income. And the species of palm fruits or palms that were available in Nigeria were the tall ones. So the farmers had to climb those tall palm trees to harvest. And then there was the high incidence of falls because the harness they used to climb were makeshift. But after 30 years or so, when a revolution led to, the plantation of, shorter palm trees, falls was almost completely eliminated, was nearly eliminated from the causation of spinal cord injuries, and road traffic accidents took over. In fact, showing that just one move, in the agricultural sector, in the technological sector, that can knock off the risk factors can actually reduce the incidence of neurotrauma. Well, as I've said, road traffic accidents are responsible. And the reason being that the roads are in bad shape, traffic laws are usually not obeyed. In this picture, you will see about 5 people in one motorbike, none wearing a helmet, and they could see the overloading here. This is what you see in many instances. So because of this, it's not difficult to infer why road traffic accidents are very common. Now, a paper from Ghana showed on etiology of trauma in Kolebu, one of the largest center in that country, over 18,000 trauma cases in a 2-year period. Also showed that road traffic accidents were the most important cause, and then head injury was responsible for trauma-related injuries in 32.5% of the cases. We will also have to remember that gunshot injuries are common in sub-Saharan Africa because of conflicts and wars, terrorism, civilian assaults. This is the case of a 47-year-old doctor with gunshot injury in 2016. And this was as a result of a land dispute. And in one of our papers, we examined the issues and the drivers of civilian penetrating gunshot injuries in Enugu, and actually found out that it is quite a common occurrence in our environment. Now, in some parts of northern Nigeria, occasionally we have cases of suicide bombing, in Maiduguri and some of those places in the northern fringes, even though that is reducing recently, but there was a time it was of concern, and then had so many patients with head injury resulting from that. There are other contextual factors. The fact that we observe peaks during festivities, whether it's religious festivities or cultural festivities, and there are seasonal variations that occur. In this instance, in this picture, you will see a 42-year-old male with an open, TBI, sustained by a machete during one of the cultural festivals in southeastern Nigeria. In this festival, people wield knives and actually can, inflict injuries on other people. So in the care of neurotrauma in sub-Saharan Africa, is mainly into the hospital care and chronic care follow-up and outcome. Out of hospital emergency care, which is a term that has been adopted by the African Federation of Emergency Medicine to encompass the full spectrum of emergency care provided to trauma victims outside of the hospital. And this includes first responder care, emergency medical services, and all forms of pre-hospital services. In Nigeria, the Federal Road Safety Corps, which is a kind of a paramilitary kind of corps that is responsible for ensuring safety on our highways. And the training for taking care of, functioning as first responders, is also incorporated into their training. And many times, some of us have been invited to go and train them on handling neurotrauma cases. But this group of people are equally inadequate because sometimes they are also hampered by logistics. But by and large, they provide fragmentary forms of pre-hospital care in Nigeria. Now, the status of pre-hospital care in sub-Saharan Africa is an area where there is a significant gap. And the reason is that the health system investments in sub-Saharan Africa mainly focuses historically on the development of primary health care centers to address the high rates of communicable diseases, which are very, very prevalent in these environments. And with competition for meager and lean resources, cases of pre-hospital and post-crash care becomes is not a priority. It's not prioritized by most governments, and this is where advocacy has to come in, because we now know that in 2030, from estimates, that the head injury will be causing more deaths than malaria and preterm delivery, together. And these entities are some of the things that are focused on in this the development of these primary healthcare policies. Emergency medical services. If we review what happens in Ghana and Nigeria, it's a same region, two countries, but different tales. Nigeria, a country of over 200 million people. We have no national ambulance service. The ambulance service in some, there are ambulance services in some states, some rich states like Lagos, Enugu, where I practice, and Rivers, and the Federal Capital Territory. Now, these ambulance services are fragmentary. There is no kind of connection or cohesion. And so it's really left at the whims and caprices of whoever is in government. And so even though in Lagos State, you have even an air ambulance service, but how effective are these, is something that has to be, that is not very clear. And that brings, the question as to, how long, do we need to wait to, have a national ambulance system? And so because of that, the transport of trauma victims is mainly by commercial vehicles, private vehicles, and then, of course, a few of them through the road safety corps. But in Ghana, a country of over 30 million people, you have a national ambulance service that has been there since 2004. By 2013, there were 33 ambulances and over 500 emergency medical technicians already trained. And the scope has since been expanded. And so that is one, area in the sub-Saharan Africa, in West Africa, where you have some form of organized emergency medical services. Now, in the emergency room care, primary surveillance resuscitation, in this picture, you will see someone in a crowded emergency room trying to resuscitate a patient. Of course, you could see that is just resuscitating with bare hands. And so most of the time, the facilities for resuscitation, including oxygen, may not be all the time available. Even though there are some changes trying to improve all that, you see that there's a lot of handicap in the emergency room care. We use the ATLS protocol, and almost all doctors, nurses, and healthcare workers are trained in this ATLS, at least in the basic trauma life support, and then in the advanced trauma life support. Basically, what you will do is airway with spinal protection, and a patient who has a head injury is unconscious must have a neck collar, and then the movement has to be synchronized. We have to make sure that the patient is breathing, you give oxygen support, circulation, disability, and then you expose and evaluate the patient sequentially. Now, neurological assessment and functional classification is very important, using the Glasgow Coma Scale, which is taught and very widely used. And then we use the pupils. We look at the pupillary response, the motor system, the head, ear, eye, nose, and throat, spinal column. And then we do a functional classification. In our study in 2013, published in Nigerian Journal of Medicine, we found that 33% of patients with TBI had severe head injury based on the Glasgow Coma Scale score. And then 18.5% had moderate head injury, while 48% had severe head injury. The indications for neuroimaging, and this is where the Nigerian Academy of Neurological Surgeons Neurotrauma Committee has done a lot of work. Professor Emejulu and his team, and they published the work in World Neurosurgery Journal, and looking at the indications for neuroimaging. All patients with Glasgow Coma Scale less than 15, open skull fracture. The reason being that, if you have someone who goes home and deteriorates, you may not get him back. So we have a low threshold for CT. And so patients that you have any doubts as to the best time to image them is when they are in the hospital. Then open skull fracture, focal neurological deficits, and so on. And then for the imaging of choice is a cranial CT, which is more available in many centers, in sub-Saharan Africa now. But the other indications for CTs can include all gunshot injuries, assaults, and all alcohol-associated injuries. From the work I did,
Yes. Can you please, we're running a bit over the time, so you still have 1 minute left, please.
Okay. So so for the neurocritical care, we have a protocol of maintaining oxygenation and CO2 tension at safe and at those parameters that I've mentioned. And then we rely on non-invasive monitoring because ICP monitors are not usually available. And so we have clinical monitoring, and then also we add to some monitoring of the SpO2, PaCO2, and then we do a CT follow-up. If GCS deteriorates by 2 points, we repeat CT. Well, the non-operative management of traumatic brain injury is is what we offer to those who don't have any indication for surgery, and that includes over 70% of brain trauma patients. For post-traumatic seizures, we have an index which we have developed locally that we use to gauge the risk and apply. The indications for trauma craniotomy will include refractory raised intracranial pressure, expanding mass lesions, gunshot injuries, brain impairment, and so on. Now, in the UNTH, for patients with traumatic brain injury, we have our records show, our publication shows the mortality of about 5.5%, which ranges from 1.7 to 15%. In spine trauma, the imaging of choice is MRI, even though it's not available in many centers. Sometimes we use the CT and complement with X-rays. And currently we have a spinal protocol which we apply to all patients with spinal cord injury, and there's an increment in operative management because we now have better facilities, more training, and all that. Now, I would say that the contextual issues in neurotrauma management in low resources include, chronic care of neurobehavioral complications like post-traumatic syndrome, then occupational therapy, and we need to define whether the exploratory boreholes are still required because this is useful in some centers, especially where there are neurosurgeons. There have been some local techniques in Africa, in sub-Saharan Africa, which is helping. For instance, some people have developed some form of traction devices and some form of air mattresses that can be used for managing patients with spinal cord injury. Then task shifting and task sharing. Trauma surgeons for TBI, where there is no neurosurgeon.
Professor Uche, you need to sum up now. Last sentence.
Yeah, I'm almost through. So the recent push by the national the NANS Neurotrauma Committee is very, very important. Trying to get a trauma registry which is region-based, and then there is a need for more advocacy and then research for the identification of biomarkers of neurotrauma. Of course, global collaboration is helping out. For instance, our collaboration with SANC has helped a lot with improving facilities in our center. So all manners of surgical treatment for neurotrauma is now possible. We have to look at the conceptual models for disparity measures in trauma care. And this will include in looking at provider access, indication detection, progression to surgery, and receipt of optimal care. In conclusion, I would say that neurotrauma care there's been some progress in sub-Saharan Africa, but there are still significant gaps, which include trauma systems upgrade, provider access improvement, workforce training, trauma infrastructure. And our recommendations is that there should be a national neurotrauma plan, and global collaborations for training, research, and audit with surveillance should be encouraged. Thank you for your audience. I welcome you to the University of Nigeria, and thank you for inviting me.
Thank you very much, Professor Uche. Despite your horrible picture, I know it's a very nice place to be in Nigeria, and I've always been very well received there. So it was a very colorful presentation of the very special conditions you work with. And you also showed the same as the other, how you have to adapt your strategies to what you have. So I hope we can go on the questions. Would you like to start, Nicolo, with the questions from the audience?
Yes, we have some questions from the audience. Most of them are open questions, so any one of the speakers are welcome to answer to the question of the audience. The question is there any program in place for a general practitioner to be educated more on neurotrauma surgical training at a distance? So if anyone from Dr. Rubiano, Professor Dr. Lucina, or Professor Ucci want to respond, it would be great.
Can you go on a boot camp on distance, Professor Lucina? Is it possible?
Yes, actually, educated a general practitioner. Okay, that's what we're doing now. The neurotrauma bootcamp that we air via hybrid. So we have people attending on the face-to-face right there on the area, but we also broadcast this to countries in Southeast Asia. So general practitioners are those people that listen and participate, so they get to benefit from the didactics. But if you are there, then you would have demonstrations on how to intubate properly, for example, in an emergency room with the possible neck injury. So all those things. But it can also we also did that in Zamboanga last year. We had breakout sessions in which we had some demonstrations on that. We also even had sessions on emergency burhole. Those were for general practitioners, family physicians, all those things. But it's if you are saying it's like, for example, we give you license to do that, then it has to be, for example, what I'm doing in my locality is task sharing. My general surgery residents are doing emergency life-threatening neurotrauma cases. So that is task sharing. But the strict thing there is there has to be oversight, meaning you have to train them and then you have to keep on monitoring. And even if I'm outside of the country, they can do the procedures there in the Philippines, in my area.
Thank you so much. So I'll take the next question. I think I give it to Professor Rubiano. Is there any global network of the TBI involving developing countries where you can be a part of?
Now there is a global interest in neurotrauma care. There are some different networks that are divided according to the theme or the thematic. Is, for example, we have global groups working in neurotrauma research, like the one that I mentioned about the University of Cambridge and the NIHR. We are now near to 20 countries, mostly from Africa, Southeast Asia, and there are groups for people that are generating educational material. So it's totally focused on what you want to do with that network. So networks are already established and depends on how you want to integrate to that network.
And how do you get in contact with them?
There are websites for many of these organizations that you can access to, or definitely many of them are in contact with all the continental societies and the local societies that are already involved working with them. So through the World Federation of Neurosurgical Societies, in this case, the European Association, for example, through your committee, and many of the committees that are already established working with that, EANS, for example, in Africa, are integrated to many of these groups.
Thank you.
Thank you, Professor. We're going to take the next questions that is addressed to all professors. So maybe we can split it in three. If you have to choose 3 practical and more effective actions to improve immediately TBI management in your centers, which one would you choose? Maybe the first will be Professor Ucci, followed by Professor Lucena, and then Professor Rubiano.
Thank you very much. If I understood very well the question, three strategies you would like to adopt. I will look at improving the pre-hospital services, a national ambulance service with trained, ambulance technicians. And in fact, looking at more of the French German model, where the ambulance staff can actually, they are technically equipped and trained to be able to, and sometimes you have doctors following, in the team, leading the team, where you can actually administer well, established protocols of emergency medical services that can actually impact on outcome. Even though there are some papers that have looked at that and didn't see so much of a difference compared to the Anglo-American system of the emergency medical services. But in sub-Saharan Africa, that will help. The second that I feel will help is to ensure that there are trauma centers where there are equipped, trauma care at, the three trauma systems, the highest level of trauma care, specialized trauma care, and that can also offer post-fellowship training for trauma specialists and neurotrauma specialists. And that can actually help to improve the level of neurotrauma care in most of sub-Saharan Africa. The other is advocacy for the health, the government to ensure that trauma patients do not have to pay out of pocket. In other words, insurance. And that will make it possible for those who have trauma, neurotrauma, to be able to access care without having to incur adverse expenditure, or maybe they may not be able to afford it. I think these three measures will go a long way in improving trauma and neurotrauma outcomes in sub-Saharan Africa. Thank you.
Thank you very much. So pre-hospital training, great points. And your point of view, Professor Lucien?
Yeah, I agree with Professor Uche. Number one is the pre-hospital. You have to improve the EMT capacity, how they respond and how they prevent at the site of trauma, prevent secondary brain injury. So, all these measures, they should be able to be trained in that, number one. And number two, there should be a tier-based referral, strengthen the referral system, like from district hospital to the apex or the level 3, level 1 hospital, all this tier-based, meaning there should not be much delay in transferring patients from one area to the next. So this is a very this is one of the problems here in the Philippines, like trying to contact the next hospital where there is a capacity to treat a neurotrauma patient. So we need to improve that in order to be able to improve also the care. And number 3 is the neurorehabilitation, because even if we operate on the patient and there's motor paralysis, that can still be addressed, and not just physical rehabilitation, but also the neurocognitive and behavioral rehabilitation. Those are the 3 areas that we need to improve in order to address all these neurotrauma patients. And tying up everything, there should be government involvement, so that, as Professor Uche said, it should not be much out of pocket, because it can be very expensive to spend for a neurotrauma patient. That's all.
Great. Thank you. Thank you, Professor Lucina. And Professor Ubiano, your 3 most important effective action to improve TBI management in your centers?
I think this was already discussed with the Lancet Commission paper related to the output of the center and the track TBI. The first one is what has been mentioned, improving per-hospital care in less resources settings. That's critically important. The second one is generating innovation, integrating new tools and new technology to the process of care. As has been mentioned now, for example, Professor Lucen and Professor Uchi have been mentioned about the importance of really do triage for managing patients, because in many of these regions, you don't have enough resources for taking patients to other centers. So the key aspect is to really triage them very well. We know that 70% of the patients with TBI are mild cases or cases that do need advanced care. But because we don't have how to identify it, that's the question, that's the main barrier. So if we integrate, for example, telemedicine, all the non-invasive systems, you really can be generating a specific selected cases that really you need to focus on the most severe ones that really need to have some specialized cares. And now, for example, that we are in the era of biomarkers will be creating an important scenario in order to really understand the primary damage and the secondary damage of these patients in order to be triaged. So that's the second one. And the third one is definitely organized, protocolized care. Many of these studies, you know, the Crevice study, the Civic study, all these projects that have been moving around integrating protocols of care have demonstrated that even in places that do not have too many resources, if you organize a protocol of care, that improves the outcome of the patients just because of the organization of the care. So that limits the heterogeneity of decision making when people do not have really good experience working with these patients. And what you try to avoid with all these protocols is also to avoid the nihilism of didn't take care of the more severe cases, you know, the self-fulfilling prophecy that unfortunately in the most severe cases is really standardized in many regions of the world, is that the patient is too sick. I don't do nothing because he's too sick. So the patient die and you say, oh, the patient is going to die anywhere, but it's because you didn't have aggressive care of the patient. So that's something that you can reduce organizing protocols of care.
Thank you. Excellent answers, all of them. So this next question is to you, Professor Andres Rubiano. And question maker, thanks you for your magnificent presentation. And I ask two questions. One, if you are in a rural setting and you get a patient with severe TBI and you don't have a means of referral, you don't have a CT scan, what can you do? Is there a role for mannitol or dexamethasone?
I think this scenario is a very common scenario and include many of these things that we have been discussing. So if there is not immediate means of referral of the patient, there are no CT scan available, the question is where you are, what resources do you have? So for example, if you don't have a CT, but you have, for example, a spectroscopy to understand if there is a bleeding inside the skull or not, or you have an ultrasound and you can define if there is increased ICP or not inside this patient, there is somewhere that you activate a different protocol. But if you are in an area where you don't have anything, you need to concentrate on the main resuscitation of the patient, as Professor Oche has mentioned, assure the basic stuff, oxygen, blood pressure in order to try to avoid any secondary injury. And then if you talk about starting empirical management with hyperosmolar therapy, definitely mannitol will not be the best option. Now, it's more safe to use hypertonic saline, but if there is no possibility of prepare hypertonic saline, or there is not hypertonic saline available, then mannitol will be the only solution that you can have to treat the patient. And steroids definitely in the acute phase are not recommended. Steroids are more focused for managing patients that have vasogenic edema, and we all understand that vasogenic edema regularly can be present in around 5 or 7 days after the injury, so it's not common to have vasogenic edema in the very beginning of the case. So maybe dexamethasone is not the best approach.
Yeah, good. And the second question is, are there full waivers for residents in low and middle-income countries on the global neurotrauma course, where you are a key organizer and instructor? That was a very concrete question.
Yeah, no, definitely. I think we are now working with many of the organizations and supporters of these organizations in order to create specific waivers. As we mentioned, we are now developing courses in Africa and in other regions. We just come from a very small neurotrauma course for ambulance providers in India during the last ICRAN meeting. And what we are working hard with our sponsors is to have possibility to waiver this, not only for residents, but for all the practitioners in different regions of the world. Now we are into the next online program for nurses, that this is an open invitation for nurses that want to be part of the online diploma from the foundation. And also there is an online diploma for neurosurgeons and residents and intensivists that are really successful programs. So what we are trying is to really spread education in order to improve the outcome of the patient.
Thank you. Thank you very much, Professor Rubiano. I picked the last questions from the audience. Is there an established pathway for residents with interest in neurotrauma to apply for these fellowships, or are all applications individualized? I think this is an open question, so if any of you would like to take it.
So I can mention for our program, we have a specific global neurotrauma fellowship. It's totally free. It's at no cost. And we have an stipend for the program. It's a 1-year program. But we also have specific rotations for residents from different regions of the world that come to have experience through their program MOUs with different universities and institutions in order to generate this type of MOUs for all these rotations. So it's an open pathway for people that really need to or want to be focused in neurotrauma care that include not only neurotrauma per se, but also neurocritical care experience and also global neurosurgery experience, because we have been mentioned the importance of developing this global neurosurgical aspect.
Okay, there are some new questions here also about physical therapist, Andres. Is the course open for that, for them?
The one that is for nurses, yes, is open to physical therapists.
Good. And then I have one other question to all of you that's also mentioned in another question about advocacy. You have all mentioned that because this is something that is very expensive for the society, neurotrauma. And how do you reach the decision makers? How have you done in your life, in your careers? Have you been able to reach them and change things?
Yeah. Okay. So I'll answer how we are starting. We are launching the Neurotrauma Society of the Philippines. So with the society, we can do a lot. Meaning, if we gather all these people who are involved in neurotrauma care, we can actually, number one, our aim would be a neurotrauma registry. So when you have that data, you can present this to the government. So we are on, those are the plans as of now. So we have been coordinating with the local first, not the national government yet. Awareness has been, there are 3 main groups of islands in the Philippines. So Luzon, Visayas, Mindanao. We already held our neurotrauma bootcamp in the Mindanao region. We are now in the Luzon region, and then Visayas region will be next year. And then we will consolidate everything, present that to the national government.
Okay. Thank you. Any other comments?
Can I have a general question for everyone, also for the speakers?
Hello, sorry. Hello.
Yes.
Professor
Yeah.
Rucci?
Yes, I would like to just make a little comment. Actually, about a month ago or so, I had my inaugural lecture in the university, and one of the presentations focused on the prevalence of neurotrauma and the complications and the outcome. And following that, there's a lot of advocacy going on with some state governments. In fact, I've been invited by some of the officials, top officials, to discuss about what to do to improve neurosurgery generally, and then neurotrauma care. And in fact, there are fruitful decisions and discussions that are ongoing as a result of that. And I hope that this might help in establishing emergency medical services in one of those states, which might be also something that other states may look at, and probably maybe nationally. So I think there's a lot of advocacy projects that are ongoing in sub-Saharan Africa. And then this is just one of them. Thank you very much.
Thank you.
Thank you, Professor Rucci. Yes, I wanted to ask to all the speakers, what do you think that the EANS, specifically with our Global and Humanitarian Committee, could do to improve or somehow to mitigate the inequities in the neurotrauma care between high-income countries and LMIC? Is there something specific actions that we could address, some educational activities, and any suggestions for us?
Yeah,
Thank you very much.
sorry.
Okay.
Sorry. So with suggestions would be collaboration, meaning if for example we have this neurotrauma society in one country, then we can collaborate not just for education but also for training, like what the Professor Andres and others have been doing, like global neurotrauma care, global neurosurgery fellowship that can be offered at a lower, costing, and then those trained would come back and advocate for all these improvements in the setting, and also not just education, but also maybe what the Professor Andres was saying was that to gather the not that expensive what's this instruments that can help, not just the training but also like pipilometer, all these things at the emergency room.
I think an important aspect is this type of exercises that you already start, like generating spaces where you can discuss the topic. Another important issue is to maintain the topic into the main conferences of the different associations, because unfortunately we have been seeing many international conferences from different associations that even didn't have neurotrauma topics into the conference, or even didn't have a specific global neurosurgery topics into the conference. So I think it's a very important task of the committees to maintain the topic and motivate, especially the new people that is coming from the countries where the society is working, like improving this access of the residents to these different topics and motivating them, organizing and participating into the international programs and rotations through the committee. The committee could be a really good filter for, identifying people that is really motivated to work in these different environments. And definitely, the committee is very important, and I really appreciate the opportunity to have the topic of neurotrauma within the committee webinars. And I think it's a really great way to start.
Thank you. Professor Rucci, last words?
Yeah, thank you very much. I think I will like to emphasize the part of training. For instance, in Sub-Saharan Africa, especially in Nigeria and Ghana, you have a lot of new fellows who wish to improve their experiences and their skill sets. And I think the EANS, if there are trauma fellowships or other forms of fellowship that can, very young fellows can be exposed to, techniques and strategies for managing trauma in high-income settings. They will use that to add to the experience in managing trauma in the low-income setting, and then all that will improve the way trauma is managed. Again, if we can share experiences with the emergency medical services, how they are organized in the high-income countries, and then we can modify in our advocacy if we have inputs from high-income countries about how things are done, and then we modify based on our content. We will have a richer experience to share with our governments and bodies that are important in shaping policy. Again, research, trauma research, identifying the biomarkers of neurotrauma. This is one area where there's a lot of gap. And then finally, fine-tuning the local technology that is available in some places. If people who have been able to innovate can find some support in terms of support from the EANS, giving them opportunity to come and present what they have innovated, and then supporting them to be able to make it a wider scale, something that can be applied across wider fields in sub-Saharan Africa. And then, of course, supporting the Neurotrauma Society. The Nigerian Academy of Neurological Surgeons has a neurotrauma committee that is working very hard. It will be good for that committee to collaborate with EANS to be able to fine-tune some of their policies, train more people, and then pursue the advocacy that we're talking about. Thank you.
Thank you so much. Thank you, all of you. You've done a great job. And there are so many keywords, but it's training, it's advocacy, register to know the data, of course, and also adapt to what you have, the local conditions. I think we have learned a lot. And Nicolo, we just mention upcoming webinars because this is our first. Do you have the dates and the themes for them?
Yes, the next webinar will be in June, the 12th of June, and it will be about residence training in low resource settings. And the third webinar will be in November. At the end of November, it will be ethical and legal aspects in global neurosurgery. And we have a fourth title that we hope to find a place where to.
Yeah. Okay, and so I thank you all, and I also would like to thank all the participants. We have a lot of participants today. It was more than 100, I think, when it peaked, and that's good, very good. And I think there are, I don't know how many countries, but it looks like they were all from all over the world, actually. So thank you so much, everybody.
Thank you.
Have a great morning, evening, whatever.
Nice.
Whatever time it is.
Thank you, everyone.
Yeah, bye. Bye-bye.
A great event.
Yeah.
Bye.
Bye-bye.